Bateman is here from Sheffield, and we've got Asit Arora, who's down in London, and we're going to talk about how we set up and run our tracheostomy MDTs. Just a few sort of ground rules. You'll notice that your microphones are switched off. That's because we weren't sure how we were going to manage the number of attendees that joined us. But the chat screen at the bottom section of your screen as you're viewing it is live, and if you want to ask any questions or make any comments, please feel free to type into that box at the bottom, which Melody has just cleared for us. We've got some questions which have been asked in advance of the meeting, and we've got those here, and so I'll ask our two presenters. The questions have been emailed in already, but if you think of any questions as you go through, please do add them to the chat section. We're going to ask you for feedback not only on the content of the webinar, but also on the platform and the way we've delivered it, and we really will use that to develop and enhance the future webinars. So I'm going to start by talking to Neil and Asit about the multidisciplinary tracheostomy teams that they both set up. And I'll start just asking Neil just a couple of questions about what made him and his team in Sheffield start to want to develop a multidisciplinary tracheostomy team. And then I'll ask the same question to Asit in a moment. So Neil, what made you start the MDT?
So I think there were really two main drivers that made me think it was a good thing to do in our children's hospital, because I'm primarily a paediatric otolaryngologist. That was the risk of adverse events, and I felt that we would have a much better grasp of what was happening to patients and a much better idea of patient safety if we took a proper multidisciplinary approach and really used that to keep tabs on patients. And also, we have a lot of patients who spend a lot of time, if you like, in the sort of process of care, especially patients who are long-term ventilated patients, babies with tracheomalacia who are trache-vented, if you like, and they spend a lot of time on a high dependency unit. And we really were interested in trying to minimize the amount of time that we spent waiting for various things to happen. Okay. So those were those two main drivers.
Okay. And I know, Asit, that the group you were working with down in St Mary's, you've published quite a lot of your work down there, but could you perhaps just reflect on some of the sort of key drivers for you in setting up your tracheostomy multidisciplinary teams?
Brendan, the key drivers for us were the fact that on an adult level, because the team that we set up was for adult care as opposed to Neil's paediatric, we felt that at a local level there was suboptimal levels of care being delivered. And in addition, when you look at the national situation, it very much mirrored what was going on locally. And when we looked at our critical incidence analyses year on year over a 3 to 4 year period prior to setting up the MDT, what we saw was a year-on-year rise. And when we looked into that in a bit more detail, what concerned us was that the reasons for the year-on-year rise of those critical incidents that were being reported were due to the management of the tracheostomies in an emergency scenario, and very much like what Neil mentioned, the time that a tracheostomy was...
Okay. And There's been
was in
various
situ.
different models of
And we
of
looked at these
MDTs
two
that have been
aspects and
published
thought, well,
that
we
know
can.
about,
I think we can do
from
something
within
to
and
address both of
without
these
the GTC.
issues.
So perhaps just Neil, I could start with you. So you've set up MDTs in both the paediatric hospital you work in and also in the adult hospital across town in Sheffield. So perhaps you could just explain to us a little bit about how those teams were structured to start with and how those teams evolved. And then I'll ask the same question of Asset and the St Mary's team.
So I think I should probably reserve talking about my experience trying to set up an adult MDT when we talk about problems with setting up the team, okay, because I really hit some stumbling blocks in terms of setting up an adult team. My pediatric team is really a process, it's still in evolution. So we have an otolaryngologist, which is me and my colleague. We have a clinical nurse specialist, and I really think my strategy in trying to establish the team has really been in trying to empower my clinical nurse specialist, who really keeps a record of all the patients that we have in the hospital with a tracheostomy, and essentially leads the round and tells me where to go. So we have her and me, we have our fellow who is there for educational purposes and to contribute. We have now established a paediatric intensivist on our round because so many of our patients are ventilated.
Okay.
And we are in the process of establishing a speech and language therapist on our round. Okay. So we are a couple of steps at least behind the Mary's group, but really I think it's about tailoring the personnel on the round to who you feel it would be helpful. I know that the Mary's group have a dietitian on the round, and I don't think that would probably be of much additional help in a paediatric setting, certainly in our hospital.
Sure. Okay. And Asset, if I could just direct the same question to yourself. So I know St Mary's have published a number of occasions with different team makeups. So perhaps you could just tell us how things started and how and why you involved those additional members.
Indeed. So to start with, before we thought about a team, the most important thing was trying to identify standards of care and specifically to see what was out there that could perhaps guide us in terms of what we should be trying to achieve. And so actually when we looked at this, certainly nationally, we were able to find some very reasonable excellent guidelines, and it happened to be from a London hospital. It really could have been from any hospital. You know, the point was there was a group had put some thought into putting together a checklist, and so what we did is we added to that, and we created, something called a tracheostomy care bundle, and we felt that there were 7 basic pillars of good tracheostomy care that we felt needed to be adhered to. And once we'd identified those 7 pillars, we then put together a team that could review patients on a regular basis, where the time for review in terms of the participants was safeguarded. And this was pretty much done on goodwill, on volition. And to start with, the team consisted of just 4 individuals: an ENT surgeon, a speech and language therapist, a respiratory physiotherapist, and an outreach intensive care nurse. And behind the intensive care nurse and the respiratory physiotherapist was a respiratory physician and an intensive care physician that could provide
Okay,
the
thanks. That's very
Maybe we
useful.
should get
medical
Asset to
backup
talk us through the
to
pillars,
the allied healthcare professional
you
that was
mentioned the
actually coming
7
on the round
pillars.
on a weekly basis.
Asset, can you talk us through that?
Yeah, so this is very much coming from work that's been done by an excellent group at St George's Hospital, which is a London teaching hospital, and um, and we've added to that. So specifically, humidification, the care of a tube, specifically the patency of the tube, and whether or not the tube is a single lumen or a double lumen tube. So, in other words, the care of the inner cannula, the fact that safety equipment should be by the patient bedside, aspects to do with the tracheostomy tube cuff and the measurement of the pressure associated with the cuff, the dressings and tapes and making sure they weren't soiled and changed on a frequent basis, that there was a weaning plan documented, and that there was an overall care plan. So this is what we defined as the 7 pillars.
Just while we're talking about the
tracheostomy care, and we call that our tracheostomy care bundle.
Of when you run into problems,
and it was this that we audited.
That when we're advocating to people around the world, you must set up a tracheostomy multidisciplinary team. The benefits are pretty obvious, but I think what the participants are interested in is the nuts and bolts of how we set that up, and I think it's useful to share our stories and experiences when things haven't gone quite so well. So perhaps I could start with Neil, because I know you've had your fair share of difficulties in trying to establish these teams.
So setting up a paediatric team, I think, was actually very easy, because I was surrounded by people who were very enthusiastic to help, because my children's hospital is much smaller than my adult hospital, and everybody who I spoke to or contacted was only too keen to participate. And I think I'd also had targeted people who had a particular interest in tracheostomy care and who appreciated the issues. Mm-hmm. When I approached my colleagues on the neurosurgical ITU at our adult trust, I got a complete pushback. Mm-hmm. They said, it's no problem, we don't need a multidisciplinary tracheostomy ward round, we're quite fine as we are. We have a speech therapist who comes to the unit on a regular basis, so we don't need you, thanks very much. Because they were doing perk trachs on all the patients and felt that they didn't have a problem. Of course, when I asked them, so what happens to the patients when they leave the neuro ITU with the trachea, they were unable to tell me. Mm-hmm. And so I'm still working on them from that point of view. I think it illustrates a point, and I was slightly guilty of this myself, in thinking, well, I think I'm a relatively good airway surgeon. I think we have pretty good nursing care, and I think I can do a tracheostomy, and I think our nurses can look after a tracheostomy. Mm-hmm. But actually, when you have patients distributed around the hospital on different wards and different units, trying to keep track of them, and actually being readmitted for other medical problems with a tracheostomy, it creates more problems than you think it will. And I think it wasn't until my clinical nurse specialist came to me and said, this is a problem, because other people are making decisions about our patients, the intensivists are making decisions about our patients without talking to us, that you realise that there is a potential issue.
Yeah. And I think this is where some of the elements we've put together in the GTC can really help, that
Absolutely.
notion of joined up care.
Absolutely.
Where the team is making decisions
Exactly.
about the patients
Absolutely.
all at the same time. And
Absolutely.
certainly that's borne out by individual experiences, institutional experiences, and then some of the literature that's been published from within our group and also elsewhere. And I wonder if I could just ask you about some of the difficulties that you came across with these MDTs, and then how you and your teams you're working with overcame those problems.
Yeah, I mean, it's so interesting to hear Neil's experience. I mean, because I think there are certain things that are always going to, in many ways, make setting up a team a challenge, and the local politics can come into play. The feeling that certain individuals or specialties feel threatened, and actually, the overriding compelling argument is in the data. And if there's good evidence, then it's very easy to persuade your colleagues that what you're doing is for the benefit of your patients. And the whole point about setting up multidisciplinary teams is that no matter how wonderful we all think we are, actually, you do need the help of your speech and language therapist, your physiotherapist. And actually, what happened with our group was, as Neil alluded to earlier on, is that having audited and shown improvement on a pilot basis level, in fairness, but nevertheless, we did show a reduction in some of the reported clinical incidents, and the suggestion of an improvement in the time taken to get a tube out. And on the basis of that, people sat up, took notice, and thought, well, okay, let's be part of this, and the team grew, and so from starting from 4 people, we then suddenly had support from a dietitian, support from respiratory and intensivists in I guess in a fact that from a clinician perspective, it was very valuable that that actually either my colleague Bill Oldfield or my ITU colleague Carlo Gomez or myself or Tony Narula, ENT, could take it in turns as the medic, to lead the round with the support of the AHPs. And I very much think that model worked very well for us. And just to sort of also add the point that to reiterate the point that Neil made, which I think is such a good point, is the more you do this, the more you actually find problems and realize the need. And what we found was almost a 2-spike sort of graph. We found that there was a group that were very straightforward to decannulate, and that process could be very much dealt with by the AHPs. And that there was a slightly more complex group of patients, the neurologicals or the patients that were surgicals, and that required a bit more time and a bit more review. And in some instances, the input of your respiratory colleague to pop down a flexi bronch to get the tube out or to facilitate good care. So we very much found 2 groups of patients. The patients that could actually were very straightforward and whose tubes could be gotten out within a few days, because actually didn't
we are in the process of
intensive medical
input.
Subsidiary that care could be done by the physiotherapist weekly
round,
and then the second group that were a bit more complex.
We see all the tracheostomy patients at the Sheffield Children's Hospital, and then a second round where we would see the edited highlights, as it were. And we're in the process of setting up this second round where our clinical nurse specialist selects which patients we would see for those that need particular attention, because we recognise a very, very similar situation. Although our patients are children with longer term tracheostomies, almost for the most part, there certainly is a group where you are putting a tracheostomy in, educating the parents, getting them up to speed prior to discharge, and then there's a group with far more problems like the need for ventilation or aspiration or just general difficulties with the tube. And so we're instigating a second round where we can look at those patients in more detail.
Okay. One of the things that I was interested in establishing from the two of you was what the sort of weekly pattern of the round looks like, and Neil's just alluded to what happens beyond the ward round, if you like. And I know your setup asset is being a weekly ward round. What happens in between those days where you're not rounding as a formal trachea MDT? If a patient needs input on a Wednesday and you've done your round on a Monday, how does that system work?
There's a established means of communication, and that is on the basis of a respiratory physiotherapist who can always contact and escalate a potential problem in the interim between the weekly ward round to the way it's set up at St Mary's is that there's always someone that holds an on-call bleep, and therefore is contactable, and therefore can contact the ENT doctor that's responsible for doing that round on a weekly basis to flag it up. So you're absolutely right. There does need to be the mechanism for not just a weekly review, which is done within a group scenario, but also that robust mechanism of communication, such that if something arises in the interim,
there was
there's a
two
means
other
of
areas that I
escalating
wanted
it,
to cover when we're setting up
such
trachea
that a review
MDTs,
might
which are,
need to be done
issues that
prior
I
to,
had, and perhaps some strategies for trying to
if
engage
required.
colleagues and engage the hospital management. In that, when I've been around trying to engage people in my site and other sites, almost everybody thinks this is more work. And what I think is very important to persuade people is give them that example that it's not just extra work. This is doing your same work that you're doing already, but doing it in a different way. And what we found is this example of the truly multidisciplinary care, where instead of having a patient on a medical ward, for example, with a tracheostomy, who is the medical team need some help, so they ask the speech and language therapist to come, who may well come on a Tuesday, who then wants the ENT surgeons to see the patient, who will come on the Thursday, who suggests we get the respiratory physios to come, who will see them the following day. So instead of us all doing all these little bits on individual days, actually going around together and having that conversation at the same time actually makes care a lot more straightforward and actually saves a hell of a lot of time. The other problem that I've had is in trying to get protected time for clinicians and nursing and allied health staff to build this into their job plans. And I think we'd fall back on Tanis Cameron's work, who I know is listening, and I always reference what Tanis and the TRAMS team have done, and they've very eloquently been able to describe the cost savings associated with joined up care. And we all do it slightly differently, but it's pretty clear that if you put that effort in, almost everyone that's published the impact of MDTs has been able to demonstrate a reduction in length of stay, a reduction in the severity of harm, and you can infer from that that you're going to save some money. And so we've managed to secure some funding at our hospital on the back of what we predict that we're able to save in some of these quality metrics. And I think that there's information out there from within the GTC and also outside of the GTC, which you can take to your managers, take to your clinicians, and really try and get them on board and get them engaged in what we very strongly believe is going to improve patient care, make your lives a lot easier, and also save your institutions some cash by saving length of stay and improving the quality of the care that we're able to do. Okay, so we've covered there how we've set up the teams, we've covered how the teams operate, we've covered some of the barriers that we've tried to negotiate while we've been developing our tracheostomy teams. I'm aware that there's some questions that people have emailed in advance of the meeting. And perhaps while we're working through these questions, I'd encourage anyone that's live on the webinar, if you do have anything that you want to ask the three of us or within the group, just to use the chat text function, which you all have access to. But we'll start, perhaps, Neil, just going through some of the questions that we've had emailed in.
Sure. So Darren French from Wichita Falls, who I note is listening, has asked, is it recommended to have a physician on the rounding team or just have a physician as needed? Asit, what are your views on that? Do you always need a physician on the team?
I think that if you have the luxury of engaging with either a respiratory physician or an intensivist, that it really does just give you, I mean, for me, I think it just gives you that essential, balanced view that you know, as a surgeon, you see a patient and a problem in one way, and that's what the whole MDT process is all about. It's about sort of seeing the same problem but in a different angle. So if you are able to convince a keen and interested physician, be it an intensivist or a respiratory physician, then I think that it's an invaluable addition to your group. I think I'd just like to make two other points, if I may, and that's that it's incredibly important that a member of the group is in some way prospectively logging the patients that you see. And Brendan's talked about this and safeguarding sort of funding. And I think that it's incredibly important for the success of not only individual programs, but also for the success of the collaborative, that it's only as good as the data that gets in, that's put into it. And I would encourage you to read Tanis's data, because just to reiterate the point that Brendan made, she's very eloquently shown some very compelling evidence to undertake this kind of project, where ultimately the managers are interested in cost savings.
Certainly from our
I think
point
that's
of view,
an important point to make.
I
think the other point to make is the educational program.
We wanted to set
because that goes hand in hand.
Was that major decisions about children's tracheostomies were only made by the team or with discussion with the team. So it's important that the team has a leader or people within it who feel able to make those decisions, and that usually amounts to a physician, but not always, certainly. I mean, I'm all about empowering others, certainly.
I think certainly the way we work here, it's the people on the team are people who are competent to be on that team, and we rely extremely heavily on our specialist nursing staff, on our excellent speech and language therapists who take a lot of the lead a lot of the time. But as Tanis has just mentioned on the chat function there, and as Neil has said, I think having a clinician, preferably senior clinician, somebody with a sort of, as Asit says, a rounded view as well, perhaps of not just where you can stick a knife, if you'll excuse me, surgeons, but the rest of the patient as well. I think that's important in getting the decision making, and as Tanis has just chipped in a timely manner. I think clinicians are very good at, or some clinicians are very good at helping drive those decisions and to move things along. Yeah. So I don't think it's essential, but I think it helps.
Yeah.
I can see Darren's typing something, but perhaps we'll just take the next question, Neil. And then
so the other question that Darren had was, how many days a week should the team round? Maybe I'll put this to Asit first, and then we'll see if Tanis has something to add on the chat. Asit.
Well, I think in an ideal world, the way we set it up was to do it on a weekly basis. Now, we all know that, you know, that people are on leave, etc. And I think that come what may, you really do need to do things on a regular basis, and to establish that pattern and that that sort of feeling that if I'm not going to be able to participate in the round, that I email to say I'm not going to be around, because of course it also depends on how many patients you've got to review. And you know, if you've got sort of 6 or 7 patients to review, of which 2 or 3 are complex, then you need to plan accordingly. Ideally, you know, you need to see patients on a weekly basis. Occasionally, that's not. We live in a, you know, we live in a realistic. We need to be realistic. But I think that to defer to something like once monthly,
Sure.
for me, I don't think that would be.
I'm interested
sufficient.
actually in your experience, Asset,
you know,
as to how long
once a week, ideally,
rounds take,
once every 10
and
days
how many
at least.
are typically included in them.
So this is a really good question, because this is hopefully going to help people that are going through that process of setting up a round. Because what we found initially was that the rounds took rather a while. Nevertheless, what we did is we basically safeguarded an hour initially, and that was between the hours of 8 a.m. and 9 a.m. And we found that we could generally get through most of the patients, if not all of the patients, most of the time. But as years went by, we actually streamlined and did exactly what you mentioned you're going through at the moment. We managed to very much tailor our ward rounds and work in a far more work efficient manner, such that actually the more straightforward cases were actually being done and seen and led by the AHPs. And that therefore meant that we could actually do a round which involved either myself or a respiratory physician or an intensivist, you know, in something like about half an hour, because we'd only be probably seeing the patients that required that input. And there were usually only a handful of patients that did, because the majority of the patients, about
used to going on the round
of the volume,
and knowing all
was
the
being
issues
done in a
and
very
being
straightforward
used to the
fashion.
multidisciplinary care packages are just as quick as and timely as they would be if there was a physician involved, or is that am I jumping?
Absolutely. No, absolutely. And that's why I wanted to bring in this concept of the educational program, because without a robust educational program, you know, your workload will unfortunately remain onerous. But if you can instigate a decent educational program, then you can actually delegate and devolve the caseload into the complex and the more straightforward.
I certainly echo,
and the more
I certainly
straightforward can be
sympathise
dealt
with Darren's
with
point about
very
getting physicians to coordinate. I noticed Tanis has contributed that they round on a Monday and a Thursday, and in the morning the nurses and the allied health professionals meet and prioritise the patients, and then presumably they have a very a fairly selective policy as to who the physicians round on. They will see new patients, those with new medical issues and decannulation decision making, which seems a very reasonable and sensible way of going about it, isn't it? Absolutely. Darren's Asset, were you going to say something? Asset.
I was just going to say that, again, it's interesting to see Tanis's comments about we always see new patients and sometimes we cancel around. And, I would say that's exactly the same. I mean, it really is. I mean, you don't necessarily have to do around if things can be discussed with the AHPs.
And then Darren's
but the point
last
is
question
that
was,
if there's a
what's
new
the best way
patient,
to capture any adverse events?
then certainly that's why you do need that robust structure.
Well, perhaps I'll turn this over to our tracheostomy safety specialist and ask Brendan.
Most hospitals in the UK working in the NHS, we have something called a critical incident capture system, which is a hospital-wide thing. Hospitals use slightly different systems, but ultimately we have to send packets of data to a national data warehouse, which is owned by the NHS, every 3 months. Data is de-identified locally and it's all sent. We then get that reflected back to us and we can search for tracheostomy or keywords, etc. So this is how we capture these events in the NHS. Now, not everybody reports critical incidents for a number of reasons, and I'm sure they're familiar to a lot of you, but I'm sure we've all done things we're not very proud of in our professional careers, and you don't always want to tell everyone about them. And there is evidence that only about 1 in 10 critical incidents that happen are actually reported, and that's been pretty robustly done by people, I think it's called SARI, who looked at hospital notes and pulled out what they found to be critical incidents that were documented or from the observations, and they then tallied that with what incidents had actually been reported. They did that for about 10,000 sets of notes, and this is where this figure about 1 in 10 came up. So we know that adverse events occur and they're not always reported. Now, the GTC database includes adverse incident event reporting, and it's one of the most powerful ways, I think, to capture any learning about tracheostomy care. The work that's been done already about adverse events has highlighted the sort of recurrent themes in tracheostomy care, which we've tried to address through the work of the GTC and the various components that make up the GTC. And so adverse events and their capture is really important, and the GTC database gives you the tools to do that. And I've certainly been using the database when we trialled it to try and capture events here, and I found that to be as useful as our current NHS reporting system.
They're a very powerful driver to change.
Absolutely.
Absolutely.
And I think some of the reports have happened into adverse events. If you work in a big enough place looking after enough patients with tracheostomies, you're going to have some adverse events. And if it's not happened this year, it's going to happen. And what we've tried to do by pooling together in the collaborative and getting as much data, information and people together with these sort of experiences is to try and future-proof our members in that we don't want you to have to go through the adverse events that we've all been through in order to drive change. And again, when I'm going out to other hospitals in the UK, we can say, look, you're going to have these adverse events. Please don't have to go through the coroner's court or go through these legal cases where you have to explain these problems in your care and the deficiencies in your care and why you weren't doing this for these patients. We've all been there, we've done that, we've come to the other side, and it's an opportunity, I think, for hospitals to learn from each other, learn from our experiences and hopefully reduce those incidents and use the resources in the GTC to try and stop these things happening. It's inevitable that these are a high-risk bunch of patients, but certainly a lot of the recurrent themes which have happened are ones that are amenable to these prospective quality improvement strategies.
Yes, I agree. I'm lucky enough to work in a hospital where there's a very low threshold for reporting an adverse event. I used to think it was too low because I kept getting forms through for things that I didn't even think were a near miss. But actually, I think there's a lot to be said for a low threshold for reporting adverse events because they are a very powerful driver.
Absolutely.
Asset, what are your views on adverse